مرحبا. إذا هون راح نبلش إحنا نحكي عن الفارماكولوجي of the GI. هلا في كثير أدوية، لكن إذا إحنا بنرتبهم in our mind depending على إيش هم بيشتغلوا بالضبط، وشو العائلة الفاميلي تبعتهم، والكاركترستكس خاصة بكل دواء. This will help us in the exam to answer all of the questions about the drugs. بداية راح نبلش نحكي عن الانتاسيدز. هلا شو هم الانتاسيدز؟ من اسمهم انتي اسيدز، هم آه مركبات او ادوية بيشتغلوا في المعدة عشان يعادلوا ال HCl ويعادلوا الاسيديتي تبعت الستمك. بنستخدمهم في كثير شغلات، منها انه الناس اللي عندهم مثلا جيرد، او الناس اللي عندهم اسيديتي زايدة في الستمك عملت لهم ألسرز. مع انه حاليا استخدامهم كثير قليل، الانتاسيد صار الاستخدام اكثر لل H2 blockers او البروتون بومب انهبيتورز اللي راح نحكي عنهم كمان شوي لقدام. لكن الانتاسيدز بضلهم شغلات مستخدمين، بنباعوا في الصيدليات and they're sold over the counter without a prescription. في عنا mainly لازم نفكر كentities أو كمجموعات. we have الألومنيوم antacids والمغنيسيوم antacids. الألومنيوم antacids من السايد افكتس تبعهم إنهم بيعملوا constipation وبيعملوا mal absorption، أو بتدخلوا بالabsorption of many drugs. وعندنا المغنيسيوم antacids اللي بيعملوا العكس، بيعملوا diarrhea. عندنا ألومنيوم constipation ومغنيسيوم diarrhea. والمغنيسيوم كمان عندهم، بما انهم بيعملوا دايريه، فبنقدر نستخدمهم كلاكسيتيف، يعني كدرug that enhances defecation او treats constipation. بس المغنيسيوم كومباوندز بشكل عام عندهم زي سايد افكت او نوت تيك بسيط عليهم، انهم بيعملوا شيء بنسميه الاسيد ريباوند. فلما اشوف مغنيسيوم بعرف انه بيعمل دايريه، بيعمل اسيد ريباوند. اسيد ريباوند معناها انه انا بس اوقف الانتاسيد بترجع الستمك produces acidity زياده عن قبل. فهذا this is the concept that we call acid rebound. هلا we have magnesium trisilicate, which is one antacid. It's one of the slow acting antacids لأنه أغلب الانtacids are uh, rapid acting، يعني بسرعة بيشتغلوا، يعني and they have an effect for like an hour or two maximum بعد ما تاخذ الانتاسيد. هلا المغنيسيوم ترايسيكليت هو في combination من المغنيسيوم والألومنيوم. Why? Because the aluminum has a constipation as a side effect, while magnesium has diarrhea as a side effect. When we combine them together, the diarrhea والconstipation side effects cancel each other out. فببطل عندنا side effects related to constipation or diarrhea. عندنا also one antacid is the calcium bicarbonate. هلا هون in this column بنقدر نشوف المعادلة تبعت الكالسيوم كربونات. الكالسيوم كربونات is the CaCO3، وهو أكيد راح يتفاعل مع ال HCl في الستومك. فبنشوف اللي هو بيعطيني CO2 و H2O كيلز أو كبرودكتس من هذا الرياكشن. وال CO2 لما أشوفها في أي برودكت رياكشنات يعني إنها راح تعمل لي بلوتينج أو بلشنج لما تتجمع ال CO2 في ال GI tract. وone side effects of calcium bicarbonate اللي هو لما أنا أستخدمه لفترة طويلة بيعمل لي الملك الكالي سيندروم. ملك الكالي سيندروم اللي هي سيندروم متعلقة في الاستخدام الطويل للكالسيوم كاربونات. والسيندروم هاي بيكون فيها زيادة في السيروم كالسيوم أكيد، لأنه واحد من البرودكتس اللي هو الكالسيوم. بنزيد اليوريا، النيتروجين، الفوسفات، الكرياتينين والبايكربونate level. So there's a lot, so there's increase of a lot of substances in the blood in the case of milk alkali syndrome. But nowadays milk alkali syndrome is barely seen لأنه الناس بطلت تستخدم كالسيوم كربونات for chronic use as an antacid. وكمان الكالسيوم كربونات زي المغنيسيوم antacids associated with acid rebound. هلا الصوديوم كربونات ما بيعمل لي ملك الكالي سيندروم زي الكالسيوم كربونات، لأنه ما فيه كالسيوم. فبنقدر نشوف in this equation اللي هي معادلة هذا الانتاسيدز إنه كمان بينتج لي H2O وCO2. هلأ CO2 يعني في عندي distension وbelching أكيد، لأنه CO2 دائمًا بس تكون في أي compound وتضلها في الGI tract تعمل لي distension and belching. كمان ممكن تعمل لي metabolic alkalosis in the blood نتيجة مثلًا وجود الCl- المفروض على البلد بيرتبط مع الH+ أو نعم بيرتبط مع الH+ وبيخلّص الدم منه and this causes metabolic alkalosis يعني الpH تبعة الدم ترتفع أكتر من الحالة الطبيعية. هلأ this sodium bicarbonate should be avoided في بعض من الdiseases زي مثلًا الheart failure. الناس بيكون عندهم heart failure بيكون عندهم كثير fluids في الدم وبتخلّصوا منها عن طريق الdiuretics. فأنا لمّا يكون عندي NaCl اللي هو أحد الproducts for this drug, sodium bicarbonate increases the absorption of water from the kidney. يعني بوقف إفراز المي الزائد أو التخلص من السوائل اللي بنستخدمه في الdiuretic therapy أو علاج مدرات البول في congestive heart failure. فعشان هيك مش لازم أنا أستخدم الصوديوم بايكربونات في congestive heart failure. وكمان الصوديوم bicarbonate is associated with an acid rebound just like calcium carbonate والmagnesium antacids in general. هلا راح نيجي عن التايب الثاني اللي بنستخدمه بيقلل من الاسيديتي تبع السtomach وبيرفع البي اتش، اللي هو ال H2 receptor antagonist او بسموهم انتي هيستامينز زي السيمتيدين، الرانيتيدين، الفاميتيدين والنيزاتيدين. هدول دراجز اول ما انعملوا كانوا عملوا ريفولوشن في علاج الالسرز والجاسترواسوفيجال ريفلكس ديزيز، لانه قبل كانت الانتاسيدز is not that effective. هلا ال H2 receptors they inhibit almost 90% of nocturnal acid. هلا الاسيد في الستومك في عندنا اسيد بينفرز through the daytime خلال اليوم، في عندنا اسيد بينفرز through the night time بنسميه nocturnal acid، وعندنا اسيد بينفرز مع الميلز. ال H2 receptor antagonist inhibits 90% of the nocturnal acid اللي هو بنفرز ليلا. ليش؟ لأنه النocturnal acid بيعتمد mainly أكثر شيء بيفرزه اللي هو الهستامين. احنا حكينا انه الهستامين بنفرز كفسيولوجي بنفرز من الانتروكرومافين لايك سيلز الموجودين في الاستمك بعد تحفيزهم من الجاسترين. بتحفزوا هدول الخلايا من الجاسترين بدهم يفرزوا لي هستامين. الهستامين بيشتغل على البرايتال سيلز عشان يحفزهم ويفرزوا لي الاسيدز. ال H2 receptors عندهم يعني التأثير تبعهم على الميل stimulated acid هو modest يعني مش كثير effective زي النكتيرنال acid، وعندهم 60% inhibition على daytime. وبالتالي لما على ال 24 ساعة عندهم الأسيد secretion inhibition لهم is from 60% to 70% which is a huge improvement over the antacids اللي كانوا يستخدموا قبل, but it's still not المين drug that's used nowadays إن البروتون بامب inhibitors عندهم effectiveness أعلى. هلا what are the uses أو when do we use the H2 receptor antagonist؟ we use them for GERD, we use them for dyspepsia واللي هي indigestion أو عسورة الهضم. We use them for peptic ulcer disease and we use them for the prevention of bleeding in stress-related gastritis. هلا راح أشرح أنا شو stress-related gastritis when I get into it. الجاستروسوفيجال ريفلكس ديزيز اللي هو لما يصير reflux of gastric contents into the esophagus والاسيديتي العالية تبعت الستمك بتعمل erosion ودامج وinjury to the esophagus. ف when we take H2 receptor antagonists prophylactically يعني as a prevention قبل الميلز there is healing مع انه healing is not that prominent يعني 50% بقلل من severity of symptoms. لكن there is يعني some type of healing. Although هلا we use proton pump inhibitors because they are preferred over the H2 receptor antagonists because they have more effectiveness in gastroesophageal reflux disease. We use it to treat non-ulcerative dyspepsia. هلا non-ulcerative dyspepsia اللي هي عسولة الهضم could be due to a lot of reasons. And over-the-counter H2 receptor antagonists are used to manage this condition. Also, it's used to prevent bleeding from stress-related gastritis. هلا stress-related gastritis is not stress we deal with on an everyday basis. لا, this is stress is when there's someone is critically ill in the ICU, أو مثلا this patient is a trauma patient, يعني has been in a car accident مثلا, or this patient is a burn patient. في كثير مثلا صار امبيرنس على جسمه كامل وحروق. فthis is stress والجسم بدخل في حالة ستريس. and الستريس predisposes to gastritis due to different reasons. يعني إذا مثلا الناس اللي بيكون عندهم Cushing ulcer اللي هي لما يكون في عنده head injury, this would increase the secretion of acetylcholine with vagal stimulation of the stomach and increase the secretion of gastrin. والgastrin will lower the pH, will increase the acidity, and this would cause gastritis. And another example is in burn patients. بالburn patients بصير في عندهم loss of fluids through the skin اللي صارت burned, لأن السكن زي ما بتعرفوا it protects the skin from protects the body from losing too much fluid. So when the patient loses too much fluid بطل في blood flow كافي على المعدة, and this might cause gastritis. هلا where does ال H2 receptor antagonist shine? It shines بنستخدمها ك IV over ال IV proton pump inhibitors عشانها more effective, أو يعني at least the same effectiveness بس at lower cost of treating stress related gastritis. كمان عندنا البروتون بامب inhibitors له شوية side effects في هاي الحالة, عشان هيك احنا بنفضل نستخدم ال H2 antagonist. والبيبتيك ulcer disease مع انه استخدامها حاليا صار replaced by proton pump inhibitors. هلا بالنسبه للسايد effects they're not that important. They're an extremely safe drugs, ال H2 receptor antagonist, ما عدا السيمتيدين. السيمتيدين هو اول H2 receptor antagonist, فكان فيه كثير side effects, منهم الجاينوكوماستيا اللي هي breast the development of breast tissues in males, and we have impotence اللي هي sexual dysfunction in males. ليش؟ لأنه there's السيمتيدين عنده anti-adrenergic effects. الادرينرجيك اللي هم the male hormones, it antagonizes the male hormones and causes those effects, and it might also cause galactorrhea in women, which is lactating, يعني producing milk, due to also to the effects on the male and female hormones. One important thing that we should know about H2 receptor antagonist is that they are inhibitors of the P450 enzymes, especially cimetidine. Cimetidine inhibits السيتوكروم P450, وبالتالي أي drug يصير له metabolization بالسيتوكروم B450 راح يزيد له راح يزيد الهالف لايف له, because we know that the cytochrome B450 is a liver enzyme that's used to metabolize a lot of drugs. Other drugs affect cytochrome B450 يعني of the class H2 receptor antagonist, but not as much as the cytochrome B as the cimetidine. And an important note that we should know about the H2 receptor antagonist is that they are not effective in the presence of H. pylori. And most of the peptic ulcer disease is caused by H. pylori. And also it is not effective if we keep on using NSAIDs like aspirin or ibuprofen or other NSAIDs for the treatment of some conditions. Because some people مثلا might need aspirin for rheumatoid arthritis or التهاب مفاصل or any inflammatory disorder, and they have to keep taking NSAID, and NSAIDs cause gastritis and peptic ulcers and predisposed to those kind of diseases. So we need a protective drug. And in this case, we mainly use the proton pump inhibitors, not the H2 receptor antagonists. And next, هلا we're gonna move to the proton pump inhibitors, which is the prototype drug and the go-to drug in treating a lot of diseases in the stomach and the GI tract. Now, how does this drug work? This drug is a lipophilic, weak-based, So it's absorbed in the small intestine and then it's delivered through the blood to the parietal cells. And when it is concentrated in the parietal cells after it's being protonated, and generally protonated uh, bases or protonated acids, they بضلهم موجودين in the lumen of whatever place they are in. ما بصير لهم reabsorption. ف when the concentration of proton pump inhibitors increases, the parietal cells starts working on the uh, proton calcium ATPase enzyme المسؤول عن إفراز ال HCl into the lumen. هلا it binds to it covalently يعني irreversibly and inactivates it. And when do we use the proton pump inhibitors? We use the proton pump inhibitors for a plethora of conditions and diseases, mainly gastroesophageal reflux disease, and it is the most effective agent in all forms of gastroesophageal reflux disease. We use it in dyspepsia, whatever the cause of dyspepsia it is. It has a modest activity, but there is still activity. We also use it on stress-related gastritis when there is a nasogastric tube inserted. A nasogastric tube is a tube that goes through the oral cavity to the esophagus. And if this patient is in the ICU and this patient has an nasogastric tube already, we could start giving oral immediate release omeprazole to this patient. But if the patient has no nasogastric tube, we prefer the IV H2 blockers, as I just said in the previous drug types. Also use it in some tumors like the Zollinger-Ellison syndrome, which is a tumor, it's called a gastrinoma, when there's an increased secretion of gastrin. And we use high amounts of proton pump inhibitors in this case. Also we use it in peptic ulcer disease, either peptic ulcer associated with H. pylori or peptic ulcer associated with NSAIDs. So this drug is a very strong drug and it's used in almost all cases, for a small exception, which is the use of IVH2 blockers when there is no nasogastric tube in a stress-related gastritis in the hospital. Now, what are the side effects? This drug is generally well tolerated. There is a couple of small side effects like headache, some diarrhea, abdominal pain, and dizzy. But like one of the main side effects is the malabsorption. This drug could cause malabsorption of some types of nutrients because this drug increases the gastric pH, and some nutrients and some electrolytes and some minerals or vitamins need the high acidity in the stomach to be absorbed. An example of that would be the vitamin B12, because vitamin B12 needs high acidity. So we could separate the vitamin B12 from the dietary protein that it's attached to, and then we could attach to it the intrinsic factor and absorb it. But if there is not enough acidity in the stomach, we can't separate the B12 from its dietary protein, and we don't absorb as much vitamin B12. Also, iron and vitamin C could be affected. And the proton pump inhibitors generally increase the gastrin levels. Why? Because gastrin levels increases the acidity of the stomach. And when the acidity of the stomach is decreased, this behafes the gastrin releasing cells, which are the G cells, to secrete more gastrin. So we would decrease the pH of the stomach. And this might cause intestinal metaplasia, atrophic gastritis, and some inflammation in the stomach. And also the use of omeprazole and other proton pump inhibitors could affect the absorption of some drugs that depend on the gastric acidity, like digoxin and ketoconazole. Now, the effectiveness of inhibiting the secretion of acids on a 24-hour secretion period is 90 to 98%, and compare that to the 70% that's in H2 receptor blockers. And it works for almost 24 hours, even though it has a short half-life, Why is that? باختصار, because the proton pump inhibitors, they bind covalently to the H plus K plus ATPase pump. And when this when the proton pump is bind to it covalently, it disables this bump. And in order for the body to gain its secretory functions again and start secreting acid again, it should make new proton pump and not H plus K plus ATPase pumps. So, and this synthesis would take almost a complete day, and that's why the effects stay for 24 hours. And also, it is used as part of the triple therapy for peptic ulcer disease. Uh, Triple therapy is PPI, clarithromycin, and amoxicillin. And or we could use also metronidazole instead of the amoxicillin. But it is still a part of the triple therapy, and those are the kind of drugs of the proton pump inhibitors. We have omeprazole, lansoprazole, and esomeprazole, which are could be taken as enteric coated granules. Now, omeprazole is orally, while lansoprazole and esomeprazole is both oral and IV. We have aripiprazole and the pantoprazole. Those are pH sensitive coating, which means that they are only secreted when the pH of the media they're in is neutral or alkaline. Uh, so they go through the stomach, and when they reach the intestines, the prodrug is released, and then the prodrug is metabolized, and we get the active substances. And the last, and but not least, which is immediate release omeprazole, which is omeprazole that is coated with sodium bicarbonate to protect it from the stomach acidity. And then it is released into the blood, and it acts very fast. And that's why it's called an immediate release omeprazole. Now we have other agents that we could use in the case of ulcers. We call them mucosal protective agents. Now ايش هم الباريرز اللي موجودين في الميوكوزا؟ عندنا الميوكس والابيثيليال junctions, tight junctions, they restrict the backflow of acids to the mucosa of the stomach. Also, the epithelial bicarbonate secretion helps in that, and the blood flow, the continuous blood flow, keeps on the secretion of both bicarbonate and mucus. And the prostaglandins are one of the important mediators اللي جوا جسمنا اللي بيساعدوا على keeping the blood flow to the stomach and secretion of bicarbonate and mucus. And when we're talking about the mucosal protective agents, they are agents that go and protect the mucosa from damage rather than decreasing the secretion of acids like H2 receptor blockers and the proton pump inhibitors do. تمام. وهون بنلاقي عندنا السكرالفيت. هلا السكرالفيت هو دواء بيعمل هيلينج للألسر أو بروتكتيف للألسرز. ليش؟ لأنه هلا هو نيجاتيفلي تشارجد، بفوت على المعدة و goes and binds to the positively charged proteins الموجودين في base تبعت الألتر، وبيعمل عليها زي الغطاء أو الفيزيكال barrier that protects this ulcer from further damage from the acid, and also stimulates the prostaglandinol bicarbonate synthesis and secretion in the stomach, which also gives rise to more protection to the ulcers and the mucosa in general. This is we use this to reduce the event of an upper GI bleeding in patients who are critically ill. And if we don't want to use like proton pump inhibitors or other drugs, because those kind of drugs increase the risk of nosocomial pneumonia. Nosocomial pneumonia is pneumonia that is acquired in the hospital because some bacteria or some die from the high acidity in the stomach, and if we reduce the acidity, the bacteria could live and go on and cause other diseases like pneumonia, which is التهاب رئوي. Next, we have some analogs to prostaglandin, because we said that the prostaglandin increases the blood flow to the stomach, increases synthesis and secretion of both mucus and bicarbonate, which are protective barriers in the stomach. The drug is called uh, misoprostol. So misoprostol acts like prostaglandin, a PGE1 analog, and it's the main use of this drug is in NSAID-induced ulcers in high-risk patients. So if this patient is on NSAIDs and there is ulcers, but the patient needs to keep on having or taking the NSAID, then I give them misoprostol. But this drug is not widely used because of its wide side effects, like diarrhea, cramping, and abdominal pain, and it should not be given during pregnancy because it might cause abortion or miscarriage. And next we have the colloidal bismuth compounds, which are the bismuth subcitrate and the bismuth subsalicate. Those kind of drugs, they work on a lot of areas. First, they reduce the gastric acid secretion. They have antimicrobial activity, so they help in reducing the or in eradication of the H. pylori. And they also stimulate prostaglandin synthesis, which helps in the mucus and bicarbonate secretion, and it reduces pepsin secretion in the stomach. Now it's used for a wide areas of diseases in the stomach, including dyspepsia, the acute diarrhea, and also in ulcers in the case of H. pylori, duodenal and gastric ulcers. It's used as part of the quadruple therapy. We said that we have the triple therapy for the peptic ulcer, for the H. pylori, peptic ulcer, and if this triple therapy didn't work, we use the quadruple therapy, which include the bismuth compounds. Now, side effects. Now, this drug has distinctive side effects. لازم نحفظها, very important. Blackening of the stool and the tongue, because like the people who take bismuth compounds, they notice that their stools are tarry dark, and also there's toxicity that might go and have encephalopathy happen in the body. Now, next kind of drugs are the drugs that we label them as prokinetic agents, or drugs that are stimulating the GI motility. And the GI motility of the gut or the GI system in general depends on the enteric nervous system, which is a nervous system that is intrinsic to the GI and controls all of the functions from motility to secretion. And there is a couple of hormones that we should get to know, like motilin, and this hormone stimulates muscle activity and stimulates motility and the GI, while dopamine acts as an inhibitory neurotransmitter, so it decreases the contractions along the GI tract and decreases the motility. So من هون احنا بنقدر نفهم انه اي شيء like dopamine, اي شيء dopamine agonist decreases the activity of the GI, while anything that antagonizes dopamine causes increase in motility, and it is a prokinetic agent. And those kind of drugs are used in numerous diseases, including GERD, and gastroparesis, which is like paralysis of the stomach when the stomach is not contracting due to autonomic dysfunction in patients who have diabetes. Those patients have indigestion and other symptoms of GERD because of gastroparesis. And those kind of drugs, there's a lot of types of prokinetic drugs. First type is cholinomimetic agents, which are drugs that work on the cholinergic receptors and the parasympathetic system in general. First, we have the pithanicol. Pithanicol stimulates the muscarinic M3 receptors, on the muscle cells and on the nerve cells in the GI. And it was used back in the days, but due to its wide side effects, it's not used anymore. It was used for the GERD and gastroparesis. We have neostigmine, which is also a cholinergic agent. It is an acetylcholinesterase inhibitor, so it increases uh, the amount of acetylcholine in the synapses in the muscles and the neurons of the GI of the GI system. So it is used for the treatment of acute large bowel distension, which is what we call also as pseudo obstruction of the colon. When the colon suddenly distends, and this disturbs the motility of the colon. So we give IV neostigmine for that. Now, and cholinergic effects, they include activation of the parasympathetic system, like excessive salivation, diarrhea, bradycardia, and also other effects of the parasympathetic nervous system. Other laxatives, now we're talking about laxatives. We have different types of laxatives, and laxatives are used to treat constipation and to increase the motility of the GI tract, or it could be used also in the case of preparing for a colonoscopy. When we prep the colon for colonoscopy, the colon should be empty and ready for the colonoscopy. Colonoscopy is a procedure where we insert a camera in the colon of a patient so we could see what's going on in there. So we have the bulk forming laxatives, and bulk forming laxatives are the type of laxatives that are bulk, which means they are large in size, and they are indigestible. So and they are not unabsorbable. So they don't get digested either in the stomach or the intestines, and they are not absorbed. So they stay in the lumen and they absorb water from like outside and from the environment in the intestines and in the colon, and uh, this tends the colon to some extent and increases peristalsis and increases defecation. And now this drug is practically safe. It could lead to some bloating and flatus, but that's it mainly. And now we have the dopamine receptor antagonist. Now, the dopamine or the D2 receptor antagonist, like metoclopramide and domipridone, we said that dopamine is an inhibitory neurotransmitter in the GI system. And when we antagonize the dopamine, that means we are increasing the motility and the activity of the GI system. And those agents in particular, the metoclopramide and the domipridone, they block the D2 receptors. So they increase the esophageal peristalsis, they increase the pressures of the esophageal sphincter, they increase the gastric emptying, but they don't have any effect on the small intestine or the large intestine. Also, they work in the central nervous system, so they could block those same receptors, D2 receptors in the brain, in the area of the medulla called the area postrema, which is responsible for it's also called the chemoreceptor trigger zone, which is responsible for nausea and vomiting. So this drug, those kind of drugs could act as an antiemetic, and antiemetic, which means antagonizes or stops vomiting, and anti-nausea, which also uh, makes the feeling of nausea go away. When do we use this dopamine? The main use of dopamine receptor antagonist is in gastroparesis. It is the most widely used drug in gastroparesis, which is could happen after surgery or for people who are diabetics and have autonomic neuropathy, which means dysfunction in their autonomic nervous system. So they lose control over the stomach, and the stomach is kind of paralyzed, and there's weakness in the contractions of the stomach. It's also used in dyspepsia. It's also used as an antiemetic, so to prevent vomiting. And it could be used another use for the dopamine antagonists, but outside of the GI system, is that it enhances lactation in women who just had a baby, because dopamine acts as an inhibitory neurotransmitter also for the hormone prolactin, which is a hormone that is responsible for producing milk. So if we antagonize dopamine, we increase prolactin and we increase milk production, and this helps in lactation. Now, it could be used in gastroesophageal reflux disease, but it's not that effective, especially with erosive esophagitis. Uh, and if it were to be used, it's used with anti-secretory agents like proton pump inhibitors and H2 receptor blockers for people who have refractory heartburn. So that's heartburn that comes from gastroesophageal reflux disease that can get better with any drug. Now, the side effects, we have to divide them to two types: drugs that cross the blood-brain barrier, so they could go into the brain, and those would cause symptoms in the brain or nervous system symptoms like restlessness, which is any agitation. Also, could cause drowsiness, could cause insomnia, عدم القدرة على النوم, could cause anxiety, and could cause like movement disorders or extrapyramidal symptoms, which means movement disorders like dystonia, which is spasms in the muscles, akathisia, which is continuous movements, Parkinsonian features like tremors, rashat, and slow movements, and tardive dyskinesia, which is the worst of all, when there is involuntary movements that is permanent. The domperidone does not cross the blood-brain barrier, so it doesn't have any CNS effects, but both drugs could cause increasing in the prolactin levels, and this could cause galactorrhea, which is increased secretion of milk, and gynecomastia in and impotence and menstrual disorders, and all of those are related to the prolactin hormone, which causes all of those symptoms. Now we have another type of drugs which we call the stool surfactant agents, which are they're not laxatives, but they kind of soften the stool, so they would be easier. They wouldn't be as hard to move through the GI tract, so they would be easy to move and go out. And this is mainly a problem for people with chronic constipation or the elderly because they have hard stool. So first drug is the docusate. Now this docusate it increases in water and electrolyte secretion in the intestine. So the stools aren't as hard since they have more water in them. And it is used in symptomatic treatment of constipation when constipation is chronic and causes symptoms, and also in painful anorectal conditions like people who have hemorrhoids or anal fissures. It's hard for them and it's painful every time they defecate. So we try to soften the stool as much as possible so it wouldn't hurt as much. Also, we have glycerin suppositories. Um, it's mainly for children since suppositories go through the anus, and it works by irritating the lining of the intestines. And when we irritate the lining of the stomach, this would increase the amount of fluid secreted, and this would soften the stool. We also have lubricants or emollients, and those kind of drugs, they lubricate the stool and make it slippery. So similar mechanism to the softeners like docusate, and so it increases the bulk of the intestinal contents on by all while also increasing the water content of the stool since it reduces water reabsorption. And an example of that would be liquid paraffin, which is used to prevent and treat fecal impaction. Fecal impaction, or it's when the feces or the stool is too hard and it can't move through the GI tract. So we try to like lubricate it, soften it, so it would go on and get out of the body. Next type of laxatives we're going to talk about is the osmotic laxatives. Osmotic laxatives, they are soluble and non-absorbable compounds And what do they do is that they increase the osmolarity inside the colon or inside the intestines. And when and water goes from um, toward this highly osmotic gradient. An example of those drugs would be magnesium hydroxide, which is also an antacid. But this kind of drug could cause the milk alkali syndrome also, and the surge in acid, which is rebound acid. That's in its use as an antacid, and its use as an osmotic laxative. Uh, there's some side effects for that. It could increase the concentration of magnesium and phosphate inside of the body, and this is not good for people who have renal insufficiency and diseases in the kidney. Lactulose. Now, lactulose is very important, and there's a question in the exam about lactulose, like 100%, because lactulose is used as a drug of choice in hepatic encephalopathy because it's not just a laxative; it also decreases the amount of ammonia in the blood. And we said before that hyperammonemia is a problem in people who have hepatic dysfunction because it could go to the brain and cause encephalopathy. So that's why lactulose is the drug of choice in hepatic encephalopathy. And lactose it's a disaccharide. It also works as an osmotic laxative. It brings water right into the lumen and increases the contractions and increases defecation. Now, we have also the balanced polyethylene glycol. It's a laxative solution. And this one is also important because it is used to clean the bowel before colonoscopy. A large amount of it is ingested rapidly, like 4 liters over 2 to 4 hours. And if it's used chronically for chronic constipation, there is a PEG powder that could be used and by mixing it with water or juice and drinking it regularly. Now, this solution is a safe solution, or this drug is a safe drug because it doesn't cause any shifts in fluids or electrolytes. It doesn't cause any cramps or flatus, so it's perfectly safe for this drug to be administered. Now, the next type of laxatives we're going to talk about is the stimulant laxatives, which what they do is that instead of bulk forming and or osmotic laxatives, this one directly stimulates the enteric nervous system to increase secretions and to increase contractions. So we would move the food along the GI tract. First, we have the anthraquinone derivatives, which are derivatives from plants like aloe, senna, and cascar, depending on the name of the plant. And an important side effect or an important note about the anthraquinones is that it is the chronic use of it could lead to a brown pigmentation or brown color of the colon. And this brown color is called melanosis coli. We have another drug that's called bisacodil, and this could be either a tablet or a suppository, and it is used in the treatment of both acute and chronic constipation. We have phenylephthaline, which is not used right now. It has been removed from the market due to concerns about its toxicity, especially cardiac toxicity. We have the castor oil. Now, castor oil goes into the stomach and the intestines, and then it's metabolized there to produce the ricinoleic acid. Now, the ricinoleic acid is a local irritant. So, as you said before, it irritates the lining of the mucosa there, and that would increase secretion and would increase the motility of the GI tract. And it is used mainly as a purgative, which means it is used to clean the colon before procedures. So, it like there's nothing in the colon after using castor oil in the suitable amounts. Now, next we have a certain kind or type of drug. It is the opioid receptor antagonist. And this drug also increases motility. But the mechanism of those kind of drugs or this type of drug is that it blocks the peripheral opioid receptors without interfering with the central opioid receptors. Now, the opioid, a little bit of background about this. The opioid receptors are the receptors that morphine work on opioid receptors, and they could be addictive. But we have, but those are the central opioid receptors. We have peripheral opioid receptors in the gut, and since opioids like morphine and other opioids cause constipation, then the antagonist to opioid would, of course, cause increased motility and would help in alleviating and inhibiting or decreasing this type of constipation. So we have mainly two drugs, which are the naltrexone and alvimopant. Uh, the methotrexate is used for the constipation that happens due to opioid use, because we said that constipation is one of the side effects of opioids. Um, and alpha-pan, it is used for post-operative ileus. Now, post-operative meaning after surgery, and ileus is when there is a paralysis in the intestines and the small intestine. So the small intestine can't contract and move food, and this might cause obstruction because food is not uh, going through or moving along the GI tract. And in this case, we could use alpha-pan to treat that. Now, alpha-pan is used only for short-term usage because long-term usage for it could cause or could have cardiovascular risks and cardiovascular toxicities. And this is an important note and an important side effect of albumapan. Now we're going to talk about the anti-diarrheal agents, which are agents that treat diarrhea or are used to decrease the motility of the GI tract. First, we have loperamide. Now, loperamide is an opioid agonist because we said opioids cause constipation. So it would make sense to use a drug that causes constipation to treat diarrhea. So loperamide is an opioid agonist, but it only works on the GI tract, on the opioid receptors in the GI tract, not the opioid receptors in the brain. So there's no analgesic or any addiction potential for these drugs. And what it happens is that it increases the colonic transit time. What do we mean by increasing the colonic transit time? So the the food or the bolus of food uh, goes through the colon and increases the time that the food stays in the colon is increased. And when we increase the time the food stays in the colon, that increases the absorption of water from the colon contents from the food into the blood and the circulation. So this would treat the diarrhea. Another drug from the class of opioid agonist is diphenoxylate. Diphenoxylate is also an opioid agonist, and it increases the colonic transit time. And this is very important in treating diarrhea because diarrhea goes quickly through the colon. So if we increase the time the food stays in the colon, this would help in stopping diarrhea and not secreting as much water in the stool. But diphenoxylate does have effects on the central nervous system, so it could cause dependence if it's taken in large amounts. Now, to avoid this kind of usage, people could just buy diphenoxylate, abuse it, take large amounts of it to get this effect. There's small amounts of atropine, which is a cholinergic antagonist. So if we increase the amount of diphenoxylate we take that is mixed with atropine, there's a lot of side effects. We call them anticholinergic side effects like nausea, like vomiting, sedation, a dry mouth. So this would limit the use of limit the abuse of diphenoxylate. Next, we have kind of a type of drug we call bile salt resins, like cholestyramine, colostipol, and colizolam. Those kind of drugs, they bind bile salts and they decrease diarrhea. Why? because when there is decreased absorption of bile salts, this would cause diarrhea because bile salts would act as a laxative and increase the amount of stool or the amount of feces. And this, we mainly see this in diseases like Crohn's disease, which affects the terminal ileum, because that's the place where bile acids are reabsorbed. So if terminal ileum is inflamed, bile acids stay in the lumen of the GI tract, go to the large bowel, and cause um, diarrhea. So those drugs bind the bile salts, so they wouldn't cause this diarrhea. Next, we have octreotide. Octreotide is a drug with a lot of usages. So there's a lot of uses for octreotide. It is, now what octreotide is, it is an analog for somatostatin. And somatostatin is a hormone inside the body. And somatostatin mainly inhibits a lot of the actions of other hormones in the body. So when we give octreotide, it's like as if we're giving somatostatin, it inhibits some tumor effects like carcinoid and lipoma because it inhibits the secretions of those hormones. It's used in diarrhea due to vagotomy or dumping syndrome or short bowel syndrome. Now, what is the dumping syndrome? Dumping syndrome happens when people مثلا go and have gastric bypass surgery, which is surgery for obese people. So they try to lose weight where the food avoids the stomach and goes directly to the intestines. This would cause diarrhea, and octreotide is used to treat diarrhea in that case. Also, vagotomy, when the vagus nerve is cut, this might cause diarrhea, and octreotide is used to treat that. Short bowel syndrome is the same because there is decreased transit time in the bowel. So when we have decreased transit time, so when the stool stays for a short time in the bowel, this would cause diarrhea. It is also used to stimulate motility in a lot of conditions like intestinal pseudo obstruction due to scleroderma. This is very important. If I see scleroderma, whatever, in the exam, this means that the answer is probably octreotide. It also inhibits pancreatic secretions for people who have a pancreatic fistula. Pancreatic fistula is like a duct or a connection between the pancreas and the lumen of the GI tract that keeps on secreting pancreatic secretions, even if they're not needed. And it's also used in the treatment of pituitary tumors and in gastrointestinal bleeding. And this use in gastrointestinal bleeding is very important. Now, since it has a lot of uses, it of course has a lot of side effects. So, side effects range from GI side effects like nausea, abdominal pain, and impaired secretions, which lead to steatorrhea and fat soluble vitamin deficiencies, to hyper or hypoglycemia due to hormonal imbalance because it inhibits the secretion of insulin and glucagon, which are hormones that control the level of the sugar. It could cause bradycardia, which means low heart rate or decreased heart rate, less than 60 per minute. And it causes hypothyroidism, which is decreased activity of the thyroid gland أو الغدة الدرقية. Okay, now we're gonna move to another class of drugs, which are the drugs that are used to treatment for the irritable bowel syndrome, or called بالعربي القولون العصبي. First, we have dicyclomine and hyoscyamine. Those drugs. They block the muscarinic receptors, so they are anticholinergics, or are called also antispasmodics drugs, and they're used to treat the irritable bowel syndrome. Now, in low doses, they have minimal side effects, but if we increase their doses, they're going to start having the anticholinergic effects, which are the effects that happen due to the blocking of the parasympathetic system, like dry mouth, a urinary retention, constipation. So that's why they are not frequently used, those drugs, the dicyclomine and the hyoscyamine. Next, we have the we have an aldosterone drug. Now, the aldosterone is an antagonist of the 5-HT receptor type 3. Now, the HT stands for the serotonin and 3 stands for that type 3. But this allosterone, this drug is restricted to women. Now, all of the drugs except for the dicyclomine and the hyoscyamine that are used for the treatment of irritable bowel syndrome are only restricted to women in the treatment of irritable bowel syndrome. Now, in the case of aldosterone, it is for women who have severe diarrhea predominant irritable bowel syndrome. Because irritable bowel syndrome could be diarrhea dominated, could be constipation dominated, could be a mixture of both. But in this case, the aldosterone is only used in the diarrhea dominated irritable bowel syndrome. We have also the prochlorperoxide. It is an agonist of the serotonin receptor type 4, the 5-HT4, and it's also used for the treatment of chronic constipation in the setting of an irritable bowel syndrome. So that's the difference between aldosterone and prochlorperoxide. Um, it is in also in combination with aldosterone considered an antispasmodic drug. So it's like an anticholinergic and has anticholinergic side effects. Next, we have the lubiprostone. Now, lubiprostone is a prostaglandin analog, and it also treats chronic constipation in women. How does it do that? It stimulates chloride channels in the small intestine. And those channels, when they are stimulated, they would increase the secretion of liquids in in the intestine and the increase of the bowel movements and increase of motility in general. And that's why it is used in the treatment of chronic constipation. Now, it should be avoided in women of childbearing age, like women who are thinking of being pregnant, and as other drugs in this category, it is approved for the treatment of women. The treatment in men is still under debate and still not proven. Okay, and now the next type of drugs are the antiemetic agents, which are agents that stop vomiting or a nausea that's associated with vomiting. First, we have the ondansetron and the granisetron, which are serotonin blockers. Uh, the 5-HT3 type of serotonin receptor. And those kind of drugs, they block both the central and the peripheral serotonin receptors because we have serotonin receptors up in the brain. And the main use of those kind of drugs is in the chemotherapy because the people who undergo chemotherapy have really significant nausea and vomiting. And that's why it's in those type of patients we use ondansetron or granisetron. We could also use it in nausea and vomiting after surgeries. Now the side effects are minimal. There's headache, dizziness, and constipation. And the ondansetron type of drugs is not used when the vomiting or the nausea is caused by motion sickness. It's only used due to if there is vagal stimulation and chemotherapy, because those type of stimulants they cause vomiting and nausea, and the drug of choice for those kind of stimuli is the ondansetron and the granisetron. Motion sickness has other diseases, has other drugs that could help in reducing it, and we're gonna talk about them next. And now we could also increase the efficacy of those kind of drugs if we have them in combination with dexamethasone, which is a corticosteroid, and NK1, which is a natural killer 1 receptor antagonist. Now, the NK1 receptor antagonist, an example of them would be aprepitant. It is a drug that blocks the central natural killer 1 receptors in the area postrema, which is an area of the medulla that is responsible for vomiting and nausea, and it is used in combination with the 5-HT3 receptor antagonist and also corticosteroids like dexamethasone for acute and delayed nausea coming from chemotherapy, because some types of chemotherapy have a very strong nausea and vomiting reactions. And next we have the dronabinol and then naproxen. We don't know yet the mechanism of those drugs, but we know that they could decrease the vomiting that is associated with chemotherapy. So we use them in that case, and they have very weird side effects. They are mainly central nervous system side effects like euphoria, which is a state of happiness. There's sedation, there's dry mouth, there's increased appetite, and those kind of drugs are cannabinoid drugs. So that's why they cause those wide effects, because they are psychoactive agents. Cannabinoids are drugs that include the weed or marijuana. Uh, prochloro, uh, prochlorperazine, promethazine, and droperidol are antipsychotic drugs, and they are used as also as an antiemetics because they block dopamine and muscarinic receptors. Now, those kind of drugs are not really used for this kind of, yeah, we don't use antipsychotic drugs just to stop vomiting, but those are like, they could be used, for example, someone who's psychotic and who has uh, vomiting and nausea, we could give him or her this kind of drug. We also have lorazepam with diazepam, which are benzodiazepines. They are also a kind of drugs that are used in the central nervous system. And the mechanism of lorazepam and diazepam is that they reduce the anticipatory vomiting caused by anxiety. Because, like, if someone is about to have a surgery, or if someone is about to do something that they're really afraid of doing and they have anxiety, they could vomit due to this anxiety. Those kind of drugs work on stopping the vomiting caused by anxiety. Next, we have diphenhydramine with dimenhydrinate. Those are antihistamines and anticholinergic drugs, and we use them mainly in motion sickness. Now, the drugs اللي بحكي عنهم the next three drugs, including this one I'm talking about, are about motion sickness and how we prevent motion sickness. But since this drug has uh, anticholinergic properties, it also has anticholinergic side effects like a dry mouth, a dizziness, urinary retention, cycloplegia, which is paralysis in the muscles of the eye. So someone could have like diplopia or double vision if they have side effects of this drug. Meclizine is also from the same class. It's an antihistamine and anticholinergic drug. It's also used in addition for its use in motion sickness, used to treat vertigo, which is dizziness, a kind of dizziness due to a dysfunction in the labyrinth. A labyrinth, it is an organ that's found in the ear that's responsible for balance. And when this organ is dysfunctional, this would cause a loss of balance, which is vertigo. And it has also the same anticholinergic side effects, although to a lesser extent, because the anticholinergic properties here are less than the anticholinergic properties in the diphenhydramine drugs. And the last drug is the scopolamine. Scopolamine is also an anticholinergic drug with an H1 antihistamine. It is particularly useful in motion sickness. Now, it causes side effects, but this drug is mainly used as a patch, a transdermal patch that we put on the skin, and this reduces the side effects related to anticholinergic effects. Now we have the drugs that are used to treat the inflammatory bowel diseases, which are Crohn's and ulcerative colitis. First, we have the 5-ASA, or the 5-amino salicylic acid, and this type of drug is used for the treatment of ulcerative colitis mainly. Now, what does this drug do? This drug inhibits cytokine and prostaglandin and leukotriene synthesis, which are inflammatory mediators. So those kind of substances or chemicals are secreted during an inflammation or because of inflammation, and they increase the inflammatory uh, situation, and they increase the severity of the disease. So, since 5-ASA works on them and inhibits them, this would help in treating and reducing the symptoms. It also has some immunosuppressive activity, which meaning that it inhibits the activity of the immune system, especially the T cells proliferation, because the T cell is the main cell that is involved in inflammatory bowel disease. Um, Now we use it in mild to moderate ulcerative colitis. The effectiveness or the efficacy of 5-ASA in Crohn's disease is still unproven, although sometimes could be used as a first-line therapy for this for Crohn's disease. Now, aminosalicylic acid or the 5-ASA works topically. So it doesn't work on the whole system. It only works on the place that is inflamed. And that's why we don't want it to be absorbed into the blood. We want it to work in the GI tract, and up to 80% of the 5-aminosalicylic acid, if it is unformulated, meaning it's not in conjugation with another formula or drug that helps in its absorption or decreasing its absorption, then 80% of it is absorbed. And this would cause side effects ranging from nausea to headache to bone marrow to myalgia to malaise, and also some very important and distinctive side effects that we don't see with other drugs like oligospermia, which is like decrease in the amount of sperm. So this could cause infertility, and folate deficiency. So we should remember oligospermia and folate deficiency and link them with 5-ASA because I don't see them anywhere else. Now, the azo compounds like sulfasalazine, balsasalazide, with also salazine, are ASA compounds, but they are linked by an azo, which is an N double bond with an N to another compound. And this compound could be active or could be just there, so it could decrease the absorption of the whole compound and make it work in the colon. So the main functions of those azo compounds is to deliver the 5-ASA to the distal segments of the small bowel or the colon in general, where ulcerative colitis is prominent. Examples of those drugs include Pentasa, which is a timed release microgranule. So it releases 5-ASA after a certain time interval through the small intestine. We have Asacol, which also does the same thing, but it is pH sensitive, which meaning that it dissolves when the pH is suitable. So this drug only dissolves at the pH of the colon, and when it reaches the colon, and it senses that this is the pH of the colon, it dissolves and secretes 5-ASA. And also we have another formulation or type of drug, which is the enema suppositories, which are the same. They deliver 5-ASA, but they deliver it through the colon and through the rectum, not orally, like the other drugs. Now we have the glucocorticoids or steroids, like prednisolone, hydrocortisone, budesonide. Those drugs mainly are immunosuppressive. So what they do is that they inhibit the production of inflammatory mediators like cytokines, chemokines. They reduce expression of the inflammatory cells and the adhesion molecules. They inhibit the gene transcription for enzymes that help in the inflammatory process, like nitric oxide synthase, which produces nitric oxide, which helps also in inflammation. Phospholipase A2, which helps also in inflammation. Cyclooxygenase 2, and uh, tumor necrosis factor beta. All of those are compounds that help inflammation, and glucocorticoids help in suppressing them. And that's why they are used in the treatment of inflammatory bowel disease, specifically in the moderate to severe inflammatory bowel disease. But now glucocorticoids are not useful for maintenance. Now we have to make a distinction between two different concepts, induction and maintenance. Now, Crohn's disease is a disease that is chronic, and it comes and goes, and there is like exacerbation of symptoms sometimes. So when there is symptoms, I give glucocorticoids to induce remission or to make the disease go away and to go into remission. So there's no symptoms right now. But it's not used for maintenance. Some drugs are used for maintenance, like to keep the drug in its remission and not to have symptoms again. But if symptoms show up, then I have to use the glucocorticoids, of course, either orally or IV, and some formulations could also be rectally, could be given rectally. Next, we have azathioprine and the 6-mercaptopurine, which are also immunosuppressants. They have a long mechanism of action, but to summarize it, what happens is that they inhibit the cell division and proliferation of immune cells, especially the T lymphocytes. And since we don't have proliferation and enough T lymphocytes, we wouldn't have inflammation and immune response. And this is what we mean by an immunosuppressant. But the onset of the action of azathioprine and 6-mercaptopurine needs a long time. So it starts working after 17 weeks approximately. And it is used, unlike the glucocorticoids, it's used in both induction and maintenance of remission. And when I want to get someone off of cortisol, because cortisol has very bad side effects and it's given for long times, I start giving azathioprine or 6-mercaptopurine. Now, the side effects of those kind of drugs are general side effects on the GI, like nausea and vomiting. It could also suppress the bone marrow. Why would it suppress the bone marrow? Because it's also the main mechanism of action of this drug is to inhibit the cell division, and there's a lot of cell divisions in the bone marrow. So if we suppress the bone marrow, this would cause other also manifestations like anemia or thrombocytopenia, which is decreased platelets. And there's also allergic reactions associated with those kind of drugs, like a fever, a rash, also pancreatitis, which is very important. Those kind of drugs could cause pancreatitis, which is an inflammation in the pancreas. Next, we have methotrexate, which is a drug that's also used as an immunosuppressive, or it could be used in cancer chemotherapy and some cases of psoriasis and rheumatoid arthritis. It is used also to induce and maintain the remissions in cases of Crohn's disease. Now, this disease or this drug, the methotrexate, has a lot of mechanisms. It mainly works through inhibition of an enzyme called the dihydrofolate reductase, which is important in the synthesis of thymidine and purines. Thymidines and proteins are nucleic acids that are important in synthesis of DNA. And we know that when the cells divide, they need to make another copy of their DNA, and since this enzyme is responsible for making nucleic acids that are used in DNA synthesis, this stops the proliferation, inhibits the proliferation of cells like the immune cells. And at low doses, also interferes and diminish the actions of some cytokines, which are inflammatory mediators like interleukin-1, which is very important in the pathogenesis of Crohn's disease. Now, at high doses, methotrexate is very toxic. It causes bone marrow depression, megaloblastic anemia, which is anemia due to B12 deficiency. It could cause also alopecia, which is a loss of hair, and mucositis, which is an inflammation of the mucous surfaces. And it should be avoided in patients with renal insufficiency. It could increase the toxicity of this kind of drug. Next, we have a new صراحة innovative type of drugs that have been to the market recently, that have been added to the market recently, like infliximab. Now, those drugs, all of them are they are antibodies, or they look like antibodies. Now, the infliximab is an antibody against the tumor necrosis factor alpha, which is TNF alpha, which is an inflammatory mediator or a cytokine that is important in the pathogenesis of Crohn's disease. So when I block this cytokine, I help in alleviating and treating Crohn's disease. It could also be used in patients who have ulcerative colitis that is refractory, so it is not responding to treatment. Now, infliximab, the main thing or the main reason we don't use it as much because mainly first it's very expensive, and secondly it has a lot of side effects. So it could use fever, chills, anaphylaxis. Anaphylaxis is a very serious condition where the body goes into a state of shock, uh, and like the bronchioles constrict and the blood and the heart stop pumping enough blood, and this might lead to death if it is not treated urgently. And the infliximab is contraindicated in cases of heart failure. Infliximab, what's really special about it is that it is a chimeric immunoglobulin, which means it comes from different animals. 25% of infliximab or of the composition of the infliximab is coming from mouse, and 75% comes from humans. And it's given as an IV infusion, and it stays in the blood for 8 to 12 weeks. The next kind of drug in this class is the adalimumab. Anything that ends with a umab is an antibody. So adalimumab is an anti-tumor necrosis factor therapy, is also the same as infliximab, but this one is a fully humanized immunoglobulin G antibody. Licortuzumab is also the same, an anti-tumor necrosis factor therapy, and it has less immunogenicity than infliximab. So in infliximab, a problem is that the body starts secreting antibodies against infliximab itself, while certolizumab has less of a problem in that area. The last one we have is the natalizumab. Natalizumab is an antibody, but it's not against tumor necrosis factor. It is against cell adhesion molecule A, or alpha 4 integrin subunit. So it's a kind of a cell adhesion molecule that helps also in inflammation and the binding of inflammatory cells, so they would come to the GI tract and cause the symptoms of the Crohn's disease. So natalizumab is used in patients who have moderate to severe Crohn's disease who have failed other therapy. So this is a last choice, the natalizumab. It has an acute infusion reaction, so it could cause a reaction if it is infused uh, acutely, so or in a fast manner. And it is also a humanized IgG antibody, just like adalimumab, but it's directed at another component, because the adalimumab is directed against tumor necrosis factor, while natalizumab is directed against alpha 4 integrin adhesion molecule. This drug shouldn't be used with other immunosuppressants, because if we use it with other immunosuppressants, we might increase the risk for leukoencephalopathy, which is a very rare and fatal viral disease. Next, we have pancreatic enzyme supplements. When we have pancreatic insufficiency and the pancreas is not secreting enough enzymes for in the intestines, we use pancreolipase to treat this insufficiency. And this pancreolipase has components of pancreatic secretions like lipase, amylase, and trypsin, and other enzymes that's secreted by the pancreas, and so it compensates for the pancreas. I shouldn't use this in excessive dosages because it could cause diarrhea and abdominal pains, and it's usually administered with each meal and snack to compensate for the secretions of the pancreatic enzymes. Now, the last type of drugs that we are going to talk about in this uh, final review is the drugs that are used to treat the variceal hemorrhage. Now, variceal hemorrhage, which are the bleeding of the varices, like esophageal varices. And we said that the varices are dilated veins that happen due to portal hypertension and cirrhosis. Now, the main drug, or the most used one, is the somatostatin or octreotide. Octreotide is the analog for somatostatin. So it's a drug that looks exactly like somatostatin and does its job. And what those drugs do is that they decrease the mesenteric blood flow, so the blood flow in the gut. And when we decrease the blood flow in the gut, this would decrease the pressure in the portal system. And when we decrease the pressure in the portal system, this would decrease from the dilation and engorgement of the veins, of the dilated veins, of the variceal, of the varices. And this would also decrease the probability that those varices might rupture and cause hemorrhage. And octreotide is generally administered for 3 to 5 days before we could go in and fix those varices using surgery. We could also use beta receptor blocking drugs. Why is that? Now, because beta receptors antagonists, they also reduce the venous pressures, the portal venous pressures, by decreasing the venous inflow, because they cause vasoconstriction in the portal tract or in the arteries and veins in the gut. So that's why it is helpful. But an important note is that we don't use selective beta blockers. We use non-selective beta blockers, because non-selective beta blockers block both beta 1 and beta 2. So now the only thing we have is the alpha effect. And the alpha effect causes vasoconstriction in the gut and the splanchnic nerves. And this would decrease the probability of variceal hemorrhage. And the last one is a vasopressin. Vasopressin is the hormone ADH, which is antidiuretic hormone. Now, an IV infusion of this hormone would cause vasoconstriction in the splanchnic arteries. Splanchnic are the arteries which are in the gut, and this would lead also to decrease pressure in the portal venous system, because since there's less blood flow, there's of course less blood, and less blood means less pressure. Now, back in the days, vasopressin was used to treat variceal hemorrhage, but because of its really wide side effects, it is not it's not used anymore, because it causes hypertension. It might cause myocardial infarction, which is the صدرية. It could cause an infarction in the mesenteries due to decreased blood flow. It causes also GI symptoms, and it could cause also edema and hyponatremia and multiple other side effects that were caused by vasopressin, and that's why it's not used anymore. And by this, we finish talking about the drugs that are used in the GI system. Now we're going to talk about drugs that are used as anti-parasitic drugs, either anti-protozoals or anti-helminths. We use them in protozoal and helminthic infections in the GI tract. Now, first, we're going to talk about the anti-protozoas, which we use to treat protozoas like Entamoeba histolytica and Giardia and other protozoas in the body. First, we have, I'm going to first talk about metronidazole. Metronidazole is an antibiotic, and it is used in almost all protozoal infections of the GI tract. So it's used in all the infections caused by Entamoeba histolytica. It's used to treat amoebic colitis, which is an inflammation common due to amoeba. It's also used to treat amoebiasis, which is the disease that's caused by amoeba outside the lumen, like in the liver or in other places. It's also used for giardiasis, which is the disease caused by giardia, and for trichomoniasis, which is the disease caused by the trichomona protozoa. And now we also, the side effects of metronidazole are not that much. So they might cause metallic taste, some dry mouth sometimes, and also nausea, vomiting, and headache. And we also use another class of drug that's called tinidazole. Now, tinidazole is the same as metronidazole. It could be used in all of the uses of metronidazole, but it has better tolerance and less toxicity than metronidazole, but it's more expensive, so it's not used as much as metronidazole. We also use class drugs called luminal amebicides. And those kind of drugs, they kill the amoebas that are in the lumen of the GI tract. And we use them for all types of infections of amoeba. And the main use that I should remember is that they treat asymptomatic amoebas. Because sometimes metronidazole, they treat the symptoms of amoeba because they kill amoebas, the adult amoebas, but they don't kill the eggs and the larvae and the eggs or the cysts of amoebas. And that's why amoebas could still be there, but it is asymptomatic and the patient could transmit it to other people. And those kind of drugs, mainly, we have three of them. We have the diloxanide furoate, which is a drug of choice in asymptomatic luminal infection. So if there's an asymptomatic amoebas, I use diloxanide furoate. It is split in the intestine to diloxanide and furoic acid. And it has like minimal side effects like flatulence, which is passing of gases from the anus. We have nausea, some cramps, and a rash rarely. We also have iodoquinol. Iodoquinol is also used as a luminal amebicide. It kills amoebas inside the lumen. It can kill it extra-intestinally or in the intestinal wall. We also have L-parmomycin sulfate. It is also a luminal amebicide. It can't work against extra-intestinal amoebic infections, unlike metronidazole. And now it is used for visceral leishmaniasis, which is a very nasty disease. And if there is any mention of leishmaniasis in the exam, it's parmomycin sulfate that's used to treat leishmaniasis. And paramomycin is also an aminoglycoside antibiotic that works in the GI tract because it is not absorbed. We have tetracycline and erythromycin, which is also antibiotics. They are alternative drugs if there is a problem with metronidazole or tinidazole, and we could use them for moderate colitis caused, for example, by Entamoeba histolytica, but they can't act on outside the intestines, so they are not used in cases of extraintestinal diseases. And we also have the dihydroemetine or emetine or just emetine, and we use it for amoebic colitis. We use it for Entamoeba histolytica trophocytes, not the cysts. And we use it in the cases when we can't use metronidazole, but it has very nasty side effects. So we should avoid it if we can. It could cause sterile abscesses at the injection site, which is like a collection of cells. But in this case, it's sterile, so it doesn't have any bacteria. It could cause cardiac arrhythmias, which are sometimes fatal. Arrhythmias means the heart rhythm is disturbed, and it could cause also heart failure and hypotension. And it is given either intramuscularly or subcutaneously. Now, some contraindications for drugs that we should keep in mind is that metronidazole shouldn't be given in pregnant women or women who are having babies in nursing women. Because this drug is associated with congenital malformations in babies if they are transmitted to the baby through pregnancy or through milk. Now here we have two drugs that are used for specific diseases, like the doxycycline, which is also an antibiotic. It kills Wucheria pancreafti, which causes a disease called lymphatic filariasis, and it's used for onchocercosis. Those two diseases we use doxycycline with them, or ivermectin, which is the drug I'm going to talk about next. And ivermectin also is used in the cases of onchocerciasis because it's a microfilaricidal. So it kills filariциdes, but it doesn't kill the adult worms of them. It just kills the larvae or the first stage of this filaricide. Um, and those side effects of those drugs are not uh, very severe. They're like general GI side effects. And we have the strongyloidiasis, which is an infection with the strongyloides. We also use ivermectin. Now, ivermectin is a GABA agonist. Now, GABA is an inhibitory neurotransmitter. So when it goes inside of the of this worm, it would cause flaccid paralysis. So this worm wouldn't be able to move. So it would be secreted through the feces. Now, some side effects are mild in approximately 30% of people. Some people have very severe side effects like hypertension, some bronchospasms, which is spasms in the bronchioles that might cause difficulty in breathing, and a very high fever. And ivermectin doesn't cross the blood-brain barrier, so that means that it doesn't cause any kind of CNS symptoms. And those are the uses of doxycycline and ivermectin. Now we're going to talk about anti-helminthic drugs, or drugs that are used to treat helminths. First, I'm gonna talk about albendazole. Albendazole is a broad-spectrum antihelminthic, and it's used also. Those drugs are used to treat nematodes. Nematodes, which are a type of worms or a type of parasites of helminths. And examples of those would be Ascaris, filarius, some hookworms, pinworms, and whipworms. All of them are nematodes, are classified as nematodes. We have albendazole, which is used in broad spectrum anti-parasitic or anti-helminthic. It could be used to treat hydatid cysts. Hydatid cysts are caused by Echinococcus granulosis. Some are used for cysticercosis, which is also a helminthic infection, and for pinworms and hookworms like Entropius, and also for neurocysticercosis. But in this case, I should give it along with corticosteroids to reduce the inflammation. Now, the side effects of this drug on the long term, we could have some fever, some fatigue, some abdominal distension, some pancytopenia, which is a decrease in the synthesis of blood cells, either red blood cells, platelets, or white blood cells, and a slight increase in liver enzymes. And this drug, just like metronidazole, it is contraindicated in pregnancy and in people who have hypersensitivity, because this would cause anaphylaxis in people who have hypersensitivity. And we said that anaphylaxis is not something good to happen. Now, how does albendazole works? The mechanism of albendazole is that it inhibits the microtubule synthesis in nematodes, and this would disturb its moving, and it also impairs the glucose uptake. So this nematode won't be able to consume food. We have another drug, which is the mebendazole. It has a wider spectrum than albendazole, so it's used to treat far more diseases. It has practically the same mechanism of action, and it also has some side effects like hypersensitivities, alopecia, agranulocytosis, which is a decrease in the synthesis of immune cells like neutrophils, and it also increases the liver enzymes. And this drug is contraindicated in children of age less than 2 years. Next, we have the parental palmawate. It is also a wide spectrum antihelminthic. It kills pinworms, ascaris, hookworms. But the important thing about this drug is that it's effective in intestinal tract, but not in tissues, if the infection is in tissues or in the liver. And next we have the piperazine. The piperazine is used for ascariasis, which is the disease that's caused by ascaria. What happens, or what's the mechanism of action of piperazine, is that it blocks the acetylcholine in this ascaris, and acetylcholine is important for movement, so it causes paralysis of ascaris, and then it's shedded and it's excreted through the feces. We also have diethyl carbamazine citrate. It's used for filariasis. Uh, and this kind of drug kills microfilariae and also kills the adult worms, unlike the doxycycline, which we talked about, or the ivermectin, which only kills microfilariae, it doesn't kill the adult worms. And also used for the lower infection and tropical eosinophilia, and all of those are parasitic infections. And also we use the praziquantel as an anti-nematode. I'm going to talk about praziquantel later on. Next, we have anti-trematodes. Trematodes is also a type of helminths or dedan. We also call them flukes. The big example from them is schistosoma mansoni, or japonicum, which cause liver disease, and the hematobium, which causes bladder disease. Drugs that are anti-trematodes include biphionol. It's used for the sheep liver fluke, which is the fasciola hepatica. It's called the fasciola hepatica. It's also the second drug of choice in the lung flukes. There's a trematode that causes lung disease, and this drug could be used to treat it. And now, how does this drug work, or what's the mechanism of action? It stops oxidative phosphorylation, so it stops ATP production. We also have a praziquantel. It's used for all schistosomas, and also it's used for other trematodes and other cystos, including the cysticercosis. We're going to talk about that later. We also have metryptonate. Metryptonate is a little bit safer than praziquantel, but it's also used for the schistosoma hematobium, which is in the liver. And it could be given as a prophylactic for children. So in preventing schistosoma in children who are at risk of getting schistosoma. The oxaminoquine is also an alternative to praziquantel, but it only works for schistosoma mansoni, which causes liver disease. And if there is different schistosoma infections with mansoni and hematobium, we could mix the oxaminoquine with metryptonate in this case. And the last class is the anticystodes, which are against cystodes, which are a type of also helminths. Examples of cystodes include the tinea solium, the diphenylpathrium latum, the Echinococcus granulosus, which causes hydatid cyst. So we have albendazole. We've talked about it before. That's used also to treat. The albendazole is used to treat the hydatid cyst that comes from Echinococcus granulosus. And we have the niclosamide. Now the niclosamide is for the adult tapeworms, or dedan الشريطية. And this drug, the mechanism of action is that it inhibits oxidative phosphorylation, so there's no ATP use, and it has minimal side effect. And by this, we finish the pathology for the final exam.